Hello, my name is MORTEZA RASOULIGANDOMANI. I'm third-year Ph.D. student in biomedicine engineering in Pompeu Fabra University. Title of my PhD thesis is a spine 3D patient-specific finite element model to understand proximal junction failure. Adult spine deformity is deviation of alignment of the spine in adults. Symptoms of sagittal deformity are back pain and impairment to stand up. Several treatments are available, more or less invasive, depending on severity of deformity. Surgical treatments aim to restore spinal alignment, achieving pain relief and improvement of quality of life. Spine surgeons correct the spine misalignment, then using hardware instrumentation like screws, rods, connectors, they will fix the spine to make rigid corrections. However, 57% of cases may face mechanical complication around instrumentation in 12 first months after surgery. Post-op hardware failures are rod breakage and proximal junction failure. Proximal junction kyphosis is an adjacent level pathology between mobile and fused spine segments, and proximal junction failure is a progressive form of PJK, mostly in 12 first weeks after surgery. There are some forms of PJK like vertebral fracture, implant pullout, which leads to pain, and sagittal imbalance. Hence, revision surgery will be provided. Recently, a score-based method has been proposed to improve prediction of PJK after surgery. Global alignment and proportion score uses pelvic incidence-based proportional radiograph parameters in full spine in order to predict risk of proximal junction failure. Besides the score-based predictors, my thesis follows two overall goals. First, biomechanical objective to find biomechanical descriptors to understand proximal junction failure using finite element modeling and computational simulation. Second, clinical objective to find best instrument configuration in order to decrease the risk of proximal junction failure. Regarding FEM simulations, I could generate 3D models using biplanar US images. Then full spine statistical shape models developed to be able to generate several spine morphologies. And then morphing techniques could provide a structure mesh for FEM. For FEM simulations, I'm simulating exactly what surgeons do during surgery, like deactivating capsular ligaments, then correcting spine misalignment by applying kinematic constraints, then including instrumentation, disc swelling, and weight loadings when patient stands up. I'm evaluating three competitors: screw pullout, residual stresses on adjacent upper instrumented disc, and vertebral fracture. My preliminary results for one failure case, hardware extended to 11, showed that maximum principal logarithmic strain on disc fibers of proximal level exceeds 0.4. Hence, one reason of failure is fiber breakage on proximal levels, and then by decreasing hardware density, like one vertebral level left, we can prevent proximal junction failure by increasing hardware mobility. Then I tested normal and also supportive vertebra for titanium rod, and pros and cons analysis revealed that one level left hardware density reduction is the best configuration to prevent risk of proximal junction failure. Finally, thanks to a spine surgeon, we could use these computational results for hardware density reduction in a real spine surgery in Hospital Del Mar.